Group. My name is Anoop Desi, and I'll be chairing the meeting today. This meeting is not being broadcast, but it is being recorded, and it will be available to watch on the CCG website after the meeting. Members of the public have been able to join the meeting, and some of them are already live watching it. We would be grateful if members of the public can turn off their microphones and cameras during the meeting. There is an opportunity for members of the public watching the meeting to ask live questions about any items on the agenda, or to ask for clarification if they're uncertain of anything that's being discussed in the meeting. This can be done by raising your hand at the slot within the meeting, or at the end of the meeting when I will ask for any questions, if you raise your hands using the icon on the screen. Members of the public can also raise questions by email, and we're keeping an eye on the CCG web email website. The email is nwccg.communications@nhs.net. If the question relates to an agenda item, then this will be read out at the end of the meeting. The governing body will either answer the question or defer the answer, in which case a response will be given in writing to the requester within 7 days of the question being asked, and that will be on the CCG website. I'll remind you that the governing body meeting is a meeting of the CCG which is held in public, but it's not a public meeting. Accordingly, any questions which are not related to agenda items will be answered and displayed on the website, but will not be read out in this meeting. Finally, as the meeting is being recorded and will be in the public domain, can members of the public please refrain from sharing any personal information or information relating to a third person when raising questions or requesting clarifications for items on the agenda. So thank you for that. So as way of introduction, in fact, I'll take apologies first, which is item 2. We've had apologies from Arden Ross, who's a member of the governing body, and also from Andrew Palmer and Anna Morgan, who are normally in attendance. Have there been any other apologies? Okay, thank you. So the first item is my kind of introduction and chair's action. I suppose the first thing I want to kind of report to the governing body is that the CCG has been working closely with NHS England to prepare our system to become a statutory integrated care system from April 2022, which is next year. The Health and Care Bill is going through the committee stage in Parliament and is still on track, so we expect that it will be implemented from April 22. Since we last met in September, there have been a couple of appointments which I need to make you aware, which you probably are aware of already, but if you're not, the first is that the Right Honourable Patricia Hewitt, since we last met, has been appointed as chair designate of the Integrated Care Board from April, and Patricia is in attendance in this meeting today. And the second announcement, which was made a few weeks ago, is that Tracy Bleakley has been appointed as Chief Executive Designate, and again, she will take up that post from April 2022, assuming that the bill goes through as planned. As part of that, I'd like to welcome Patricia to the meeting. She has attended the governing body before, so welcome, Patricia. And if you have got questions, and I'll give you an opportunity to say some things as well.
Thank you, Anoop.
Okay. I need to report that I have been asked to take some action as chair since our last meeting. And initially I thought it hadn't been reported in the action log. In fact, it's not in your PDF files, but it is in the separate files that you received. And the one on action logs does point to the action which was taken, which related to procurement of mental health community wellbeing hubs, adult continuing healthcare services in Norfolk and Waveney, and the children and young people's continuing care services. So because of the timescales, I was asked to take action as per our agreement earlier in the year. I asked Mark Jeffries and Arden Ross to go through that request for Chair's action, and they were in agreement that it was appropriate for me to take that action. I don't know whether Mark or, well, Arden's not here, but Mark, you want to say anything? But it seemed fairly clear cut, and the papers relating to that Chair's action will be circulated to governing body members.
Nothing to add, thanks, Anoop. I agree with you.
Okay, thank you, Mark. So we'll move to item 3, which is declarations of interest. And just a reminder, I guess, first of all, to make sure that register of interest is accurate and up to date, and that if there is any item on the agenda where you need to declare a potential or actual conflict of interest, can you do so either when we're at that item or now? So I've got a couple of hands up. I've got Rob first and then Hilary.
Yes, thank you, Chair. I'd like to note, as I normally do, that a family member is a vaccinator in the National Vaccination Programme. We have an update on progress locally later on the agenda. Thank you.
Thank you, Rob. Hilary?
Thanks, Anoop. Just to note that the item on the Way 4B development includes one of the sites, which is actually my practice.
Okay, thank you for declaring those. And I'd like, Rob, I ought to declare it's on the register, but that my partner is a vaccinator for Cambridge services as well. Okay, so item 4 is to approve the minutes of the last meeting, which we held in September. So any, that was on the 28th of September. So any items are on there for accuracy. I mean, there's quite a few pages there, so I wasn't going to go through individual pages. So there's 19 pages. So does anybody want to? Yeah, John?
Yeah, just one thing I don't think made sense, Chair, which was towards the bottom of page 4, the penultimate paragraph feels like it finishes abruptly. It just talks about discussing how this will be significantly enhanced and how the LSDD, and then stops. I wasn't quite sure what that was intended to say. So.
Yeah, it does seem a bit truncated, doesn't it? So shall we get a sense check and add some extra words to make sense of that? Thank you. Were there any other items for accuracy, first of all? No. Okay. Well, let's approve those as accurate. And are there any matters arising from that meeting which we're not covering today that people want to raise? No. Okay. Thank you. So action log is the next item 5, and we've got we've got it there with the extra action on Chair's action, but I don't think there's any items there. They're all closed or completed, so I don't think there's anything we need to cover on actions log. But I'll take any questions or comments. No, okay. So item 6 then is bang on time. Is Melanie's report as Chief Officer.
Thank you, Anoop, and good afternoon, everyone. It's really good to see you all here today. I just wanted to draw attention to 4 items in my report which are not covered on the agenda and I thought were important to comment on. Starting with the operational challenges. There is a paper later on. Mark Burgess, Mark Lim, Howard Martin are going to talk about the demands on the health and care system at the moment from both urgent emergency care, the elective recovery programme and the vaccination programme. But I really just wanted to underline the concern and risk around staff health and well-being, and I mean all staff health, whether they are frontline or back office, as we like to sometimes describe people in non-patient facing roles. The pressure on staff is just immense, and I really wanted to acknowledge as well and thank everybody for all that they're continuing to do, because what we're facing is just relentless demand, and people work in the NHS because of a passion usually to look after people and to care. Whilst this is what people have come to do, it is in very, very challenging circumstances at the moment. And moving on to then also talk about general practice, and I wanted to just highlight the campaign that Norfolk and Waveney CCG has launched just a few weeks ago to support general practice and to really appeal to the public about using general practice in the most appropriate and kindest way as well. We're continuing to see huge demand on general practice, as well as just the most amazing transformation, which is meeting lots of people's needs very effectively, particularly with improved access to digital services, which for many, many people has been an absolute life changer over the last 2 years. And then just a couple of points to finish. I've just referred to some of the visits that I've had to meet with teams across Norfolk and Waveney, and one of the visits was in the middle of October to the Queen Elizabeth Hospital, where we hosted a visit, myself and other colleagues and chief executives from across the system, for Anne Radmore, the regional director. And I was delighted to be joined by Howard Martin and Dr. Claire Hambling, as well as Dr. Julian Brown, to showcase Protect Now, something that we are incredibly proud of in Norfolk and Waveney and developed just 2 years ago. We showcased Protect Now as our population health management and risk stratification tool, and I was delighted that just last week it received an award from the Health Service Journal. So really delighted, and fought off stiff competition, and a real tribute to Howard and Claire particularly for all your work on that. And then finally, I was just so touched that Rebecca Crosley, a learning disability nurse, won the National Award for Learning Disability Nurse of the Year. And I remember it was down to Rebecca that she pioneered an accessible vaccination clinic at the James Paget Hospital some months back to encourage and make as comfortable as possible the environment for people with learning disabilities or autistic people to come and be vaccinated. Rebecca, of course, has done many other things in her career, but that was the most recent, and I was just so pleased for her that she's been recognised at this national level. So thank you, Chair. I'm very happy to take any questions if there are any.
Thank you, Melanie. Claire, and then Rob.
I just wanted to say thank you for saying thank you, but I can't really take much credit personally. There was a huge team of people involved in the COVID Protect project and in the ongoing Protect Now across lots of professional backgrounds, both clinical and in support. As you know, very many people from the CCG itself, but also people from out with the CCG and volunteers as well. So it really was a remarkable team effort, and it's, I'd just like to acknowledge everyone who contributed in any way at all to make the project such a success and to safeguard the well-being of the population of Norfolk during what was the scariest time of the pandemic.
Thank you. Rob?
Yes, thank you, Chair. I'd like to say thank you, Melanie, for a very comprehensive report and a balanced presentation of what we're seeing. I'd particularly like to commend you for continuing to visit frontline staff and having conversations with those staff, because that's a good way in which we as governing body members can understand what's happening in the world outside. So I think that's a very important part of your role, and I'm always very pleased to read that section in your reports. Thank you.
Thank you, Rob. And before I ask Tracy, can I just reiterate that as well? I was fortunate enough to attend one of the meetings that Melanie had up in Norfolk, which is my patch, we met the locality teams of the CCG there, as well as other clinicians within North Norfolk, and it's really valued by staff. And I know logistically it's quite difficult to arrange these things, but I know how much it's been appreciated by staff. So thank you, Melanie, for that. Tracy?
Yeah, just adding to that, really. I mean, again, had one of those visits through Melanie and Norwich, which I know the team really appreciated. So thank you for that. And I think, you know, clearly the operational pressures on staff in all sectors is huge at the moment. And you know, it is concerning as we're going in. Well, we're in the winter at the moment, but I just wonder if I could hear a little bit more about some of the things that we're doing in the system to support the staff's health and wellbeing. I know there's lots, but I think it'd be helpful just to know that there are things that we're doing to support staff, just so we can understand some of those, if that's okay.
Yeah. Okay. Melanie, did you want to come back on that?
Did you want me to say anything now, Tracy, or are you thinking? I think that would be really important to include in a future report, more detail around that. I think one of the areas that, you know, there's a whole huge amount of work going on to support staff in all different roles, and it ranges from really trying to focus on workload pressures, because that's the biggest driver of stress and people's intention to quit, and also how people are feeling that they're being treated at work as well is another single biggest driver of whether people are going to stay in their job at the moment. And we're really concerned about retention and, you know, as well. And then, of course, you know, other areas that are important as well to staff, including just, you know, particularly in frontline services, provision of hot drinks while they're on busy shifts. And food, you know, just some basic things that we know in the first wave of the pandemic really made a difference. But maybe that's an area that I can just come back to in my future report, Tracy.
No, that would be really helpful. Thank you. And I know sometimes it's those small things that make a big difference as well, like you said. So thank you.
Okay, thank you. Hilary?
Just in response to that, Tracy, there is a network now of health and wellbeing guardians that's been set up across trusts and across CCGs. So they are looking to share expertise, knowledge, things that they've implemented that have worked well. So we're part of that. And within our organisation, we have been recruiting health and wellbeing champions to different aspects of that role. So it is something that there is quite a lot of work going on, and you know, as Melanie said, we could bring to a future meeting.
Okay, thank you. So thanks again, Melanie, for your comprehensive report. Let's move on then to the next item, which is item 7, and really focusing on what you'd expect us to be looking at, which are the pressures, operational and transformational priorities really related to winter pressures, elective recovery and vaccinations. And I'm going to ask Mark Lim to talk to that report, which is within your papers. So, Mark.
Thank you, Noop. I'll hand over in the first instance to my colleague Mark Burgess to give the update in relation to urgent and emergency care. Thank you.
Thank you, Mark, and good afternoon, everyone. So I'll take the paper as read, but there are a few areas that I would like to pull out because I'm sure people would most likely like to discuss, particularly focusing on winter pressures, as we historically call them. The good news is that there has been extensive winter planning, and I know we've discussed this in previous meetings, not just within the NHS, but also with our council colleagues and social care colleagues, which has been a real fundamental to this. So there are 4 areas that I'd like just to kind of highlight, really. The first of those is demand, as Melanie flagged in her report. We are seeing increased demand, in particular within primary care, on 999, 111 and mental health services. It's pleasing to note that the numbers presenting at our ED on some days do peak a bit. We're not seeing drastic increases in attendances to A&E, so that's a positive to note, but something that we keep very close eye on. But obviously we are getting real pressure right across the system. So particularly primary care, 999, 111 and mental health are areas that we are seeing significant challenge. The second point, which is a real concern to us and to all of us on this call, is about the ambulance handover delays. We are seeing increased number of ambulance handover delays, and obviously that significantly increases the risk in the community. So we're working very closely with hospital colleagues and ambulance trust colleagues and wider system colleagues to see what additional steps can we put in place, and our winter planning is very much focused on that as well. We are beginning to see some initial impact on some of that, but the pressure is still in the system and we have some way to go. Thirdly, capacity and the real pressure on capacity right across the system. The report highlights around the medically fit for discharge. Patient numbers are increasing across our system. We know we've got real significant challenges in the social care sector around domiciliary care, packages of care, care home placements, and this is not just a Norfolk and Waveney issue, as we've discussed before, but it is putting real pressure on the system. So a significant amount of the investment this year for our winter funding is around trying to put on additional capacity to really support flow across the system and hopefully help flow throughout the system. And the fourth point, which is a real concern for us, is around workforce. We've previously reported we know we've got very considerable vacancy, high number of vacancies across all sectors, but sickness, and as Melanie alluded to, the well-being of staff is a real concern, and we are seeing increased levels of sickness. So it's vitally important that we do what we can in those areas. So they're the kind of four areas I think I'd like to flag as the biggest concerns. I've touched on some of what we're doing. The funding that's been identified, the schemes that we've got in place, the winter access funding for primary care, we've got approved schemes now just in the last week, which is really about trying to increase the number of appointments and services available to support primary care, to support patients across Norfolk and Waveney. The hospital discharge programme, that's absolutely about the capacity. The mental health funding is also being made available, and just to give you an idea of some of the work happening there, it was agreed just this week that the Mental Health Trust will be block booking 12 additional beds at a local in Norfolk provider to try and deal with some of those pressures that we're seeing in the emergency department, and also working with the voluntary sector actually to see how, and there's in-reach to our EDs, and the voluntary sector are working with us on that, which is very positive to see. And finally, I think the other key point is about the prevention campaign. The CCG have been working with public health and other colleagues about how we can support people of Norfolk and Waveney to keep well over winter. So we talk lots about self-care, advice and support, advice and guidance, just to try and make sure we know that there are pressures and frustrations from some members of Norfolk and Waveney. So it's important we listen to that and we put things in place to try and improve around access. So just a few snapshots of the important things around winter pressures, but it's good to see that we've got the finances approved now and we can move forward and really try and make a difference. I'll pass back to you, Mark.
Thank you very much. And do you want me to go straight to the elective recovery update or at this stage? Sorry, Noop, I think you might need to enable your speaker.
There's always once in the meeting that you do that. So yeah, I was going to say, unless people have got any comments to make on the winter pressures, we can take them as a whole in terms of comments and questions at the end. So yeah, Mark, do you want to go on to the remainder of the report?
Thank you, Noop. So for those relatively new to the meeting, we have a elective recovery board which meets every 2 weeks and is chaired by Caroline Shaw, who's the Chief Executive of the Queen Elizabeth Hospital, and people can refer to an earlier paper which went to governing body during the summer to go through the arrangements and who are the leads for the various work streams. In terms of today's update, I'd just like to highlight 3 particular things. So the first thing is in relation to what is known as H2 planning. So Essentially, all systems have to essentially submit plans for their elective recovery for the final 6 months of the year. So we have done that and agreed our plans collectively as a system. There are clearly expectations from NHS England and improvement as to what those particular plans should contain, and one very strong focus that they've put on for this particular submission is those patients who are waiting over 104 weeks. So they absolutely want to minimise that. So that's been a very key priority in relation to the planning. So we do have a plan which is compliant with their expectations in relation to that, and will require the percentages given in the paper in terms of elective activity in order to achieve that. Secondly, I just one of the queries we had at the previous governing body was in relation to the patients on the admitted waiting list. Do we check that they aren't coming to harm as a result of that? So there are two ways in which that is done. So the first is that we monitor the patients, particularly in the P2 category. So those are patients who should be treated within a month, so the most urgent, apart from the P1 patients who should obviously be treated almost immediately. And we're continuing to making good progress with that. For a couple of months ago, there were 32% of those patients who did not have a date, but now that figure's down to 13%. I'm also very pleased to report that at the Elective Recovery Board yesterday, we agreed an ICS policy for harm review, and that includes all patients who exceed their timing according to their P category being reviewed within 3 weeks of them having exceeded their category, which is a very ambitious target, but all the trusts have committed to work towards that, and that will be what is routinely monitored throughout the course of the Elective Recovery Board's deliberations. And then finally, I'd just like to point out a couple of specific innovations within our system, which the CCG has been directly involved in. So, the first is in relation to an outpatient waiting list review project. So essentially, it does use some similar principles to the Protect Now project, where we use online portals followed up by call handlers to contact patients who aren't able to have digital access, and reviews them essentially according to a questionnaire that's been agreed between primary care and secondary care, and letters for the first batch of patients in that project were sent out last Friday, and we think that's a very exciting development because this will save the specialist nurses and consultants and GPs a lot of time in checking up on these patients, and it will also enable us to very systematically collect information on what's happening to our patients who are waiting for their first outpatient appointments. Another innovation which the CCG has led on is the sort of community Tele Dermatology service, which is proving slightly more effective than we expected. So about 70% of those cases are being retained in primary care. Our original expectation was approximately sort of 60%. So it does seem to be doing well, but we are getting an evaluation from the University of East Anglia to get a more sort of objective view of its benefits for the whole system. So there's quite a lot there. I'm very happy to take questions now or after the next update. Thank you.
Okay, so any questions or comments for Mark on the elective recovery work? No? Yeah, Doris?
There was just a comment in the paper where you talked about the concerns about data in the NNUH. Has that now been resolved?
Yes, that's right, Doris. So essentially, without getting too technical in case I get it wrong, but my understanding is that there is a particular console under which they receive referrals, and it's a separate console to the one that they actually receive advice and guidance requests from. So there was a possibility that there may be advice and guidance requests which were returned through the referrals console, which wasn't counted in the data. So on further investigation, it does appear that there is missing activity in that. So the advice and guidance figures do seem to reflect, the genuine position of the Norfolk and Norwich in relation to advice and guidance, which is possibly a negative thing in one way, because there's not going to be a windfall from that data source, but we weren't relying on it. So we just need to continue our process of trying to get usage of advice and guidance up in as many specialties as possible, and consultants to provide reliable responses, which there are in many specialties, in order for our GP colleagues to have confidence in using it.
Okay, thank you. Hein?
Yes, thank you, Chair. I had a question related to what Mark Burgess referred to. There's a lot of attention, Mark, as you said, about the medically fit for discharge pool of people and addressing that. So I have a request for a next meeting in public, if you could provide an update on how those initiatives for which you've received funding are having an effect. I think it's an important area to highlight. Thanks.
Yeah, I think that's good.
Thanks, I'm very happy to.
Okay, great. Tracy?
Yeah, it might be just so thank you, really helpful update to have that. Just in respect of the electives, I might just be misreading the paper, but just some clarification. So when Mark, you talked about the H2 plans and the 104-week waits and the work in order to address that by March, which is really positive. Just confirming that it also relates to the RTT section, where it says that the number are up by a certain amount. So that they are absolutely related, because I know that in the first section with the H2 plans, it referred to the numbers in March. So just ensuring they're linked together, which I'm sure they are, but just clarification in respect of that, that's okay.
Yeah, sure, Tracy. So the H2 plan should see the total waiting list size go to 107,000 in March 2022. Obviously, that is an estimate, because obviously we don't know what the referral rates will be in the subsequent 5 months of the year, but that's the working assumption that that's where we'll land in March 2022.
Thank you.
Okay, thank you. Doris?
It's just a question for Mark in terms of impact on the care sector. Are we seeing things that were reported in the press about the mandatory vaccination? Are we seeing that impact in Norfolk and Waveney, and can we quantify it? Maybe it's too early, but it would be good to have quantification at some point.
Yes, so unfortunately we are, and working with council colleagues very, very closely about the impact. We've had lots of modelling done about the potential numbers. I think it's still very early to get the actual numbers through, but I suspect by the next meeting we'll have a better picture on that. So the kind of informal feedback is absolutely the predictions we are seeing. But we are seeing some care providers handing back packages of care, for example. I know it's not the care homes, but on the domiciliary care side as well, the council are having actual packages of care handed back to them. So Norfolk First support the reablement service of the county council, having to pick up a lot of that work as well. So it really is a great concern for us all. I think trying to put a more positive spin on it, I think the schemes that have been worked up in some detail between council colleagues and health colleagues, if we can start to really embed some of those, it should help us, particularly about clearing some of the backlog of those patients who we can't find packages of care for. So that we hope that we will start to see the benefit of that in the next month or so. But it is a real risk, and the market side of things here is a real challenge.
Can I just have a follow-up? And are we, or is anybody actually actively engaging with those colleagues in social care sector who doesn't want to have the vaccination to maybe address some of their concerns?
Very, very much so, Doris. I think it won't be a surprise to you that this is pretty much top of the worry list, I think, for council colleagues, and the impact on health as well, on the health side of things. So yes, and I think there's some quite creative thinking going on about, and some of those examples quite extreme around, is it bonus payments and things of that nature, just to try and encourage people to stay as well as come into the sector to try and support. It's it's a really feedback we have from that very passionate about caring for people, and we must support those individuals in the sector. So yes, that's a very key area of work.
Very much.
And Kath, did you want to make a comment?
Yeah, thank you. It was just to clarify that at the moment the mandatory vaccination is for people who work in a care home or enter a care home, and actually the concerns about the care workforce is much wider than that. So I think it would just be wrong to not be explicit. The mandatory vaccination is having an impact, but actually the wider care workforce is much more concerning, and the domiciliary care workforce, which are the providers that are handing back packages hand over fist, and the local authority and commission services are having to pick up the slack, which is having that impact, isn't really about the vaccination. It's about actually people wanting to work in the care market or having options now. There are other jobs that they can choose to get potentially for more money. So it's actually the care workforce for me is our biggest pressure, for which mandatory vaccination is actually a smaller proportionate issue.
I think that's a point well made, isn't it? That's a long-term issue, whereas this is an additional one which is hitting us now, isn't it? But thank you for that. Okay, Mark, do you want to? I think you've got the information around vaccinations, haven't you, part of your report?
Yes, thank you, Chair. So I'll start off with the flu vaccination, as that's probably the one that members are most familiar with. So we have essentially a trajectory, and so compared to this time last year, we are doing well. We're ahead of where we were this time last year. So for that is currently going well, and obviously will help very much in terms of our winter preparedness. So since the last update to governing body, obviously a very significant development is booster vaccinations. I think it's just worth noting that in order to have it, you obviously need to have had your second dose, as it were, quite 6 months previously. So it's not an area in which we're able to get ahead, if that makes sense. So obviously we need to vaccinate people as they come online and become eligible for that. But we appear to be doing well in that. So we've vaccinated 65% of the eligible population, and we're on sort of target to meet the 80% cumulative target that we need to meet sort of in the forthcoming months. And then finally, obviously there are now vaccination programs for older children, and the details of which are given in the paper. So I'll stop there and I'll ask questions, but obviously a huge number of vaccines developed and delivered. Thank you.
Okay, thank you. Thanks very much for that, Mark. Tracy, and then Rob.
Yeah, I just want to say in respect of both our COVID vaccination programme and our flu vaccination programme, what a sterling effort the whole system has made. Certainly, particularly think about primary care colleagues and all of our colleagues, because we are performing extremely well. And having been at the Health Protection Board this morning, where Howard presented, some of our figures in respect of both of them, it was a really positive picture. More to do, of course, but I think it's really commendable of an all-round system effort on that front.
Definitely. Rob?
Yep, thank you, Chair, and thanks both Marks for those updates. I had a question on the flu vaccination programme, Mark. I mean, it's great to hear that we're doing as well as we are doing, but there's a reference in the report to significant supply issues, which are, as I understand it, is a national issue. Could you just give us a bit of an update around what's happening there to understand that in a bit more detail, please?
Yes, thank you. I think Howard's now joined the call, so if I could pass over to Howard, thank you.
Okay, welcome, Howard. So we're on the question is around the flu supply.
Yep. So yeah, I was on the call from the beginning actually. So sorry.
Oh, sorry,
Howard. Yeah, so I think in answer to your question, Rob, so it continues to be an issue in terms of getting hold of a supply, but maybe not quite as great as we had feared it would be from the beginning of the programme. So we are actually above the trajectory that we've set ourselves, which was basically, can we do at least as well as we did last year? Because last year was a very good uptake, and we've actually exceeded that uptake at the minute. There are some specific areas of concern. I think we've touched on them previously when we were thinking about the uptake amongst our care home workers or domiciliary care. And there's quite a lot of work we're trying to do with community pharmacies, and also the development of a roving team that can go around and vaccinate as many of these people as possible, not just for flu, but also for the COVID boosters.
Yeah, that's really helpful. Thanks, Howard.
Okay. Any other questions or comments on that report? No? Great. Thank you. Thank you, everybody. We're doing well on time, so thank you for keeping to time as well. So item 8 is on the primary care hub business program business cases, and I've got Paul Hyam's name next to that, and Paul is on the call. So can I ask you, Paul, then to, assuming that people have read the papers, but can you just outline what we're being asked to approve today, please?
Hi, everybody. Yeah, so the purpose of the paper today is to seek approval from the governing body to submit the attached programme business case to NHS England. The programme business case itself is seeking to build 5 new primary care hubs across Norfolk and Waveney, which would use 25.2 million of NHS capital, and then the balance up to 47 million total project value would look to come from private investment. The locations of those hubs, if I just kind of start in the west and move east, so we're looking for 1 new hub in Kings Lynn, which would be a brand new, from primary care perspective, a brand new kind of site. The preferred locations are at the moment on Narhew's Way. We haven't, papers kind of highlighted, we haven't got a primary care provider lined up at this point. Our preference is to use a provider within a local provider. We are in dialogue with the Kings Lynn PCN, and it's looking kind of promising that we will get kind of a sign up there, which is good news. And the Queen Elizabeth Hospital would also be operating from that site, delivering diabetes outpatient services and maternity services. Next, moving east, we've got Appleborough Surgeries, which would be kind of a new build replacement on Station Road, on the Station Road site, which would see kind of demolition of the current surgery and the kind of not quite adjoining but next door NCHC owned health centre, and see a brand new building placed on that site. In addition to NCHC and Appleborough Surgeries, the NNN would like a presence in that building to deliver maternity services. Next one along the Aslake Close in Norwich, which is quite smaller, looks smaller on paper in terms of the new space. There's only kind of a 145 metres squared extension, but there is also kind of an internal reconfiguration of the practice. For those of you who are unfamiliar with that site, historically that building was built to house 2 separate GP practices. Over the years there's only 1 practice in there, which means the building isn't configured as efficiently as it could be. Nearby be Rackheath, which would be a brand new site identified on Broad Lane, which would see Houghton and Wroxham Surgery run services from that site alongside NCHC for community services, and again NNN for maternity services. And then in the far east in Galston, we can do a new build, a replacement surgery on the Shrubland site on Magdalen Way in Galston. So 4 of the 5 schemes look to create additional capacity based upon kind of increased demand for future populations. The Shrubland scheme is slightly different. Now we're looking to increase capacity we're looking to replace existing capacity. So the existing facility on Shrubland is a temporary facility, and at some point that will need to be removed because it's a modular build and it's been up longer than originally intended. Trying to kind of preempt some of the questions you might get from the body, the ongoing revenue costs of the scheme at the moment we're forecasting will be 1.1 million a year for the CCG, which is roughly 5% increase on our current kind of premises and GPIT spend. To give it a bit of context, our overall primary care allocations have increased year on year the last couple of years by an average of just over 4%. So it's kind of in line with that increase. All tenants, all potential tenants bar 2 have now submitted their letters of support, which is good news. Just need to do a final chase of the last 2 potential tenants to get those in before we could submit to NHS England. And it's important to know at this stage we're not committed to. There's no financial commitment at this stage. All we're asking the governing body for approval today is to onward submission to NHS England, which we won't get full approval until we reach the full business case stage, which is the next stage of approvals. And at that point, the scheme would then split into 5 separate full business cases instead of the one large document you've got today. But we would still look to bring those separate full business cases back to governing body for approval. It's unlikely they'd all come at the same time due to the kind of the size of the schemes and the speed that they can move. It's likely to be phased throughout 2022. We're looking to hopefully start construction, assuming everything goes to plan, in September, October next year. The sites would then be completed by March 2024, and then allow a couple of month period for kind of transition where appropriate. So all the sites would then be hopefully operational for patients come kind of May 2024. That's kind of all I wanted to say to introduce the paper. But happy to take any questions.
Thank you, Paul, for producing that and actually for presenting it so clearly. So thank you for that in terms of what we're being asked to do today, which is to approve the submission that goes to NHS England at this stage of these 5 proposals. Rob?
Yes, thank you, Chair, and thank you for a very clear and comprehensive report. It's a question really for John, and it's about the financial implications here, particularly the capital costs. Given the scale of the project, John, at 47 million, are you comfortable with those estimates at this point in time, accepting that they may change as the scheme goes forward?
Yeah, thank you, Rob. Yes, in short, I'm comfortable with them. They've been through a thorough process to get to this stage, proper professional evaluation of the bids. So yeah, I'm comfortable with those. They're in line, I think, with what we would expect, to be honest, within primary care for developments of this sort of size. So yes, I'm comfortable with those.
Great, thank you for that, John. And just a wider question, I'm not sure who this is directed to, but given the timescales for implementation, we're talking about 2024. Can I be clear that the integrated care system and the future integrated care board has been cited on this project and is supportive of it?
So from my perspective, Rob, we give a monthly update regarding the programme to the ICS estates work streams. All providers are cited on it, and they've all had the opportunity to be part of the programme and take space in these facilities. And we've also released 2 updates to the Strategic Capital Board as well. So from my perspective, all system partners are kind of cited on this.
That's really good to hear. Thank you, Paul.
Thank you. Okay, well, if there are no further questions or comments, we're asked to request the approval of the submission to NHS England and improvement of the business cases that are before you. So can I ask for your approval to submit? Okay, thank you. Let's move then to the next item, which is item 9, which is a business case for the shared care record, and that's got your name next to it, John.
Indeed, thank you. First of all, apologies, I think, for the amount of reading that everybody's had for this meeting. Clearly there was a lot for the previous item, and there's another business case which is approaching 100 pages for this one too, but there are some exciting developments. So hopefully the cover paper is self-explanatory and helps to add a little bit more as to what is a shared care record, why are we doing it, what are the benefits, etc., which is all in the business case, but just trying to pull out some of those things. But just a couple of things I'd like to say by way of introduction, really. One is, I think, to tie it back to the ICS long-term plan, we've got 3 goals. As an ICS, those 3 goals are about helping people to lead healthier lives, about making sure people only have to tell their story once, and about making Norfolk and Waveney the best place to work in health and care. And to my mind, the shared care record is a fundamental plank in helping us to deliver all of those goals, because it will support frontline clinicians and other operational professionals in delivering care to patients. It will help patients who currently, in a number of different circumstances, have to tell their story over and over again, and it will support staff to be able to do a better job for their patients. We don't currently have anything like this in Norfolk and Waveney. In fact, we've got very low digital maturity. We're unfortunately well known for that, particularly within the hospital sector. And the shared care record really sits alongside another major transformational programme within our system, which is the acute electronic patient record. Of these 2 things, if we can progress these over the next 2 to 3 years, they're going to make a fundamental step change, I think, in terms of the ability to share information for people at the point of delivery of care and really make a fundamental difference to the patients of Norfolk and Waveney. So I'm certainly very supportive of this project. I'm Joint Senior Responsible Officer for it, and as such I chair the system-wide Shared Care Record Project Board, which has got representation from all organisations across the system, including Norfolk County Council, organisations such as Cambridgeshire Community Services that provide some children's services for us, IC24, a number of other organisations that maybe aren't part of the mainstream provision within Norfolk and Waveney, and all parties are working together on this. And that group has endorsed the outline business case. So just final point is, I'm conscious there is a financial implication. So wearing my other hat from a financial point of view, should we be putting this forward at a time when we've got significant financial pressures as a system? Well, I think the answer is yes. 2 reasons really. The numbers in the paper are indicative numbers at this stage. This is an outline business case. We've done some market testing, but there was some very big variance in the costs coming through that. So it's only when we go to procurement will we have a proper handle on the cost of this. We think we've got a reasonable estimate in there. Also, there's a lot of work still ongoing to quantify the benefits that we think will come from the shared care record. So I would expect when we get to the full business case in the spring that the net cost of the system will be reduced. But also, I think hopefully the business case speaks to the very wide range of benefits that will be delivered from this, which I think unlocks a much broader scope of productivity right across the system, which I think would dwarf the cost of this. So we're asking the governing body to approve the outline business case so that we can then commence the procurement, and it also supports an application that we've made for capital funding for this for NHSX. So just before we open up to questions, I'd just like to pass over to Dr. Zach Blake, who's here today as the clinical lead for the project. I think we just wanted to say a couple of words as well.
Sure, thank you, John. So I just thought I would present a couple of mock-ups of what the system, will look like in principle, so that people who maybe aren't as close to the project could understand what it is we're hoping to deliver, and talk a little bit about how that will have an impact on patient care quality, patient care experience, and staff decision making and confidence and well-being. So if I can just quickly share my screen. Everybody see that?
Yeah.
Great. This is essentially how the system will, kind of a diagram of how the system will appear for clinicians. So their regular clinical system interface will be preserved. So, for GPs, this would show System 1. For clinical workers in NSFT, that would show Lorenzo, and for social workers in NCC, that would show Liquid Logic, and that would be their kind of regular menus and everything that they would be used to seeing. They would then select third-party information or similar from the kind of navigation tree, and then the shared care record, this area here, is what we're actually delivering, and that is all of the information that we can get into it. And I chair the frontline work group in the project, and we have input from all the major care sectors to determine what is the most important priority information, and we will then hopefully, after working with the supplier after the procurement, we'll be able to choose the exact layout so that each role has the most useful information at their fingertips to help them deliver patient care. So this will be a combination of information from multiple sources across the health and care system, and over time that will get more and more structured. To give you an example, this is a view of the shared care record in Suffolk as seen through Liquid Logic. So this was what a social worker in Suffolk would see if they looked at their shared care record. Obviously, the hospital in the West Suffolk Hospital is a much more digitised hospital than the acutes we have here at the moment, but this is obviously something we'd be working towards. And this shows that the social work team would be able to see the discharge summaries and clinical documents and investigations. And as I say, these views are customizable so that for the social work view, we'd obviously be emphasizing the information that would be most useful to social workers, such as community physio and OT assessments, rather than in detailed medication reviews and allergies and things. So I'll just unshare. So in terms of the benefits, I mean, obviously, hopefully people can understand that the benefits to patient experience are significant. So at the moment, as a GP working out of hours, if I see a patient, I clerk them but feel that they need to go to A&E, I have to write the information into the clinical system in IC24, and that's then sent through as a message to their GP, on the Monday morning for processing. It's quite a lot of effort to actually print that out and give it to the patient, and then they have to take it with them through to A&E, and then be able to use the patient as a transfer for that. And often, especially if it's in a visiting car, for instance, where we don't have the computer, it's impossible to send that information with the patient, meaning that the A&E doctor has to start completely from the beginning and the patient has to tell their story again. So even just seeing one doctor and then the A&E doctor, they have to still tell their story twice. If I was able to enter that into the out-of-hours GP system and that was shared to the shared care record, then the A&E doctor would be able to log in and see that there and print it and not have to clerk the patient again. And also in my regular primary care day job, if a patient has seen the consultant psychiatrist the previous day, usually I then have to wait for their secretary to type up the letter and for that letter then to be sent through to the practice, which can take a couple of weeks. If I've seen the patient in the meantime, I don't really know what's happened to that patient's plan. Again, the patient has to tell their story again, and then they feel a loss of confidence in me as a doctor because they would kind of expect me to know what the psychiatrist's plan was, and it damages the relationship slightly. If I'm able to see the actual notes that the psychiatrist made in clinic and see that the plan is to change to this medication, then everything is much more seamless. The patient care experience is much better. Their confidence in me as a joined up team member is much better, and it means that I'm much more confident about my decision making, feeling happier about working in a more efficient system. And it means if that patient does seem to be at a higher risk or the margins of crisis, I can make a more confident decision whether they need to be referred to the crisis team and avoid the kind of referrals that are seen quite often in the crisis team, where someone who's already under community mental health team is referred there and then actually is then immediately just discharged back to the community mental health team because it is actually in hand. So it'll improve the system from a pure efficiency perspective, as well as the patient's perspective and the staff's perspective.
Okay, thanks very much, Zach, for that, and I'll take any questions or comments. But while we're waiting for that, can I just thank you for explaining really in such clear terms what the benefits are and giving some examples, because I think sometimes we have these phrases about only having to tell your story once, but actually showing what it means on the ground. And I agree with you, it's how it seems to patients that use the service, to clinicians and others working within the system to avoid duplication. And I think the other aspect is which you didn't perhaps highlight for me was safety as well. Is that actually when you copy things over from one system to another, there's room for error, and actually having the same information being shared means that you won't get those errors occurring across that interface. So we've got a few hands up while I was talking then. So if everybody can be succinct about the point they're making, starting with Hein.
Thanks. And second team, many thanks for the document. I read it with great interest and fully supportive. I think the benefits will be plentiful, as you've outlined. I have two questions. One is around the control and ownership of data. I read it can be contractually arranged. We can access the data. So one question is, does the supplier also have access to the data in a way they can commercialize or otherwise? And the second question is around future proofing. I read the plan is after the 4 years to move to the ideal platform, but maybe you can provide some assurances around that plan.
Okay, can I suggest that I'll take a few questions and then perhaps John and Zach can try and answer them together. So I'll take Mark as well, and then Claire.
Thanks, Anu. It was just a question about the EPR, the electronic patient record that John mentioned. Just in simplistic terms, should we be seeing this as a foundation stone in the EPR, or in due course will the EPR supersede this?
Okay, I'll take one more and then we'll deal with the others. So Claire?
And my question was firstly to say thank you for presenting it, because I think it's a huge step forward, whatever, you know, even as it is. My question is around data flows going the other way. So, for example, if a patient sees a specialist in clinic, it would be really fab if that data could be transferred into primary care records in such a way that we could use. So particularly, say, the data that's applicable for national audits, so that we don't have to duplicate or transcribe, and just wondering whether there's a facility to enable that.
Okay, so can I ask perhaps Zach to start off and then John to answer those questions, and then but bearing in mind time, I'll ask Doris, Tracy and Patricia then to ask some supplementary questions.
Of course, yeah. So data ownership, my understanding, I haven't obviously gone into the nitty gritty of that element of the contract, but certainly my understanding is that it is stipulated that the data is only for use in the shared care record, and that can't be sold on, and that obviously the data will come back to us at the end of the contract through a migration or otherwise. Kind of moving on to the long-term plan question, there was some tension in the STP as a whole as to whether we should be pursuing something where the HCDA is the back end right now, providing the data from the get-go, and the shared care record is just a kind of view of that data and doesn't actually store anything, versus going for a procurement that enables both a back end to be deployed as a kind of, the term is a shrink wrap solution, so that we know that we're buying something that's going to run, you know, middle of next year or earlier. And the feeling was that we should consider the second option mainly as the part of the procurement, but it's definitely our intention. Anything that we do will be with a view to a long-term solution that is, you know, strategically consistent with the plan, and that's scored highly in the procurement. And my view would be that anything that the acute hospitals do or the other stakeholders do to share data should be through the central integration engine, which will be linked to the HCDA, and that they will be doing this once, and we'll be copying the data feed from the kind of HCDA input towards the shared care record, so that, you know, in the future we may not even need to get the data out of the shared care record supplier, we just get them to delete it because we already hold it in the HCDA. Next one was to do with the EPR. I think it is really important to understand that the EPR will be to the acutes what kind of EMIS is to GP practices, or System 1 is to GP practices. So if you have an acute admission in the acute hospital and then you are discharged to the care of the mental health trust, there will not be any flow of information to the mental health trust without the shared care record. If the acutes all buy the same provider, then yes, if you move from one acute to the other, I guess you're using the same kind of record. But when you get discharged from the acute hospital to primary care, unless they're using System 1, there will be a change in system and you'll need the shared care record to share the information. So definitely, if you want to view that information from social care, or if you want to view that information from the mental health trust, you will need to have a shared care record, even if we had an EPR. The providers are often very similar, and as I showed on that example, in Suffolk, Cerner provide the hospital EPR and also provide the shared care record, but as I understand it, there are separate contracts for both of those functionalities. The other question was about direct data entry. Certainly, we want to make sure that the data is available as much as possible for the things that we need it for, and I'm going to have work streams after the procurement is run from all the different care settings to make sure that we understand what people really need and design the displays in the way that meets people's needs the best. In terms of direct data entry, currently the understanding is that it will just be presented in that view for the purposes of direct care only. It may be that, you know, for audit purposes, or if you're doing a particular data quality piece that you might need to manually copy and paste it across. That's something we can look at as an extension in the future potentially. What I would say is that at the previous meeting I presented, there were concerns raised about direct data entry bringing risks to kind of organizational flow, in that if somebody updates something and it's immediately copied into your native system, then that could screw up all your QOF points and that kind of thing. So it is a slightly double-edged sword. The plan is currently that it is just presented for the clinician's view at the point of direct care.
Okay, thank you for those succinct answers. I'm going to take Doris, Tracy, and then Patricia for some comments and questions. So Doris first.
Thanks for the paper and for the presentation. It was very clear. I presume that the system is going to be enable where patients are referred out of Norfolk and Waveney to specialists, Cambridge or London or wherever, that there is that functionality that the same thing will work for hospitals or whatever system further afield.
Okay, thank you, Tracy.
Yes, thank you very much. And I know we had a very good discussion at the Clinical Data Committee as well. So thank you again for the presentation today, Zach and John. My question is in respect of any potential consideration for patients to access this system going forwards and for them to have a view of elements of it, but also considering if a person's choice to potentially opt out of it, some of it, whatever, because I know there's always those considerations, certainly of summary care records and data sharing. So just be interested to know how that works in this particular data sharing arrangement.
Yeah, no, good questions. So I'll ask Patricia to ask her question, make a comment. Patricia.
Thank you very much indeed. Really great to see this at this stage, and great to hear Dr. Blake explain so clearly the advantages. 3 questions. First of all, I don't really understand, I realise, the relationship between the shared care record and what we're already doing with COVID Protect, Protect Now, and all that Eclipse-based work, which actually is leading edge. You know, we are 19th century in the acutes, but we're very 21st century with that particular piece of work, as we were hearing earlier. Secondly, have you been looking at and learning from the really good work that the CCG and Eclipse did with the Ambulance Trust, where the paramedics actually designed and specified the view that they need from GP records, and indeed in some cases hospital test results, that sort of thing, now available to them and having a dramatic effect on the time that the paramedic needs to spend with the patient and the quality of the outcomes. And thirdly, I noticed that the procurement starts the day after the formal key bit of approval for the business case, and there's 2 months between the procurement starting and the choice of preferred bidder, and that includes Christmas. And I just wondered, are you absolutely confident about those timescales? Are the tender documents, for instance, already ready to have the button pressed on the 2nd of December?
Okay, thank you, Patricia. So, Zach, do you want to have a stab at those, and then maybe John might?
Yes, sure. So the first one was about patients referred out of area and then the access to the shared care record from out of area. That is definitely the intention. My understanding is that what is currently being procured will not provide that functionality, but there is a roadmap through something called the thin integration layer for that to be accessible to other regions, and that is something that is common to all the shared care record products, across the nation. The next one was about the consideration of patients to access. Yes, that is definitely within future scope, but not being currently procured at the moment. But we'll get onto procurement timelines later, but we definitely wanted to ring fence it to be as deliverable as possible within the time constraints that have been forced upon us. But yes, certainly it is within the procurement spec that is functionality that is supported in future, and that is something that we will do. The next one was a patient opt-out. Yes, again, that is supported. So if a patient opts out, then their information will not be shared, although I'm not the IG expert, I hasten to add. The next one was shared care record versus COVID Protect and Eclipse. So I'm not involved in depth with COVID Protect or Eclipse, nor have I seen their products in the last few months. However, I would say, from my understanding, the use case is very different. So that the shared care record is to be used at the point of care, so by the doctor or nurse or social worker during the appointment with the patient in front of them, for the purposes of making decisions right in that moment. And we'll take information from all of the stakeholders across the patch. And there is a national spec definition, which is called the MVS1, minimum viable solution 1, and there is a framework from which the suppliers are procured through the kind of national plan. Whereas COVID, Protect and Eclipse, certainly when I last saw those products, were used to kind of assess and audit and risk stratify patients kind of one step away from direct care, so that you can determine which patients you need to kind of make a plan to reach out to. So it's kind of happening before the appointment rather than in the appointment with the patient, which would be the shared care record. The final one was to do with procurement timelines. So most definitely the timelines are tight. So we have been advised from NHSX that we have this capital funding available, and unfortunately it has to be spent within year, and that does mean that we have to meet a deadline, but the project team is confident that that is achievable, and the procurement specification and scoring documents and everything are indeed ready to go, pretty much. John wants to come in, I'm sure. So again, I'm drifting out of my area of expertise.
No, not at all. I completely agree with what you've said there, but just as reassurance, we had the same conversation last week at the Shared Care Record Project Board, because there was a sense that certainly the timescales were very tight, so there was an action from that to try to see a way of us extending the period for bidders to put their bids in by maybe a week or so, and maybe curtailing some of the bits that happened after that. The difficulty we've got, it's so often the case, isn't it, that we're hoping to secure some funding from NHSX within the next few weeks, but that will need to be spent by the 31st of March. And that means that clearly we're therefore doing everything that we can to do a good, proper process within a relatively short timescale. Yeah. So we'll absolutely do what we can in that period to make sure we can get good bids, actually, because if it's a very short timescale, we risk not getting good bids.
Yeah.
Did you want to
Thank you. Really helpful.
Okay, that's great. Well, thank you, everybody, and particularly to Zach and John for presenting that. And as Tracy said, this came to the clinical executive as well, so we had quite a discussion there. It's very warmly recommended and received. So we'd like to ask for your approval then as a governing body for the outline business case for the shared care record to proceed as requested. So can I ask for your approval? Okay, that's great. Thanks very much for that. We'll move then to the next item. And just a reminder that we will have a short break at 3:10, so we're still on track for that, in case you're wondering. So the next item is agenda item 10, which is related to age-relating hearing loss, and a recommended option in terms of taking that forward. So I've got Karen Bryant, who is with us. So Karen, do you want to lead off the discussion on that?
Yep, thank you very much. For those that don't know me, I'm Karen Bryant, Associate Director Local Commissioning, working within Mark Burgess's team. So this item is about age-related hearing loss for patients aged 50 or over experiencing difficulties with hearing. We have a current contract in Central Norfolk due to end March next year. To note that we do intend to roll this specification out to West and East localities too, with work commencing on this next year. Unfortunately, we couldn't do it all at the same time because of the contract end date in Central, but the intention is certainly there to align so that we have consistency across the ICS. Our current tariff is comparably low, and there would be high risk of no provider submitting a bid or issuing a legal challenge if we didn't actively address this, hence the business case and the updated service specification that you have. Both have been informed by national guidance, a helpful supplier engagement event, clinical executive committee, finance committee and executive management team. There are a range of options included in the business case looking at different potential tariffs, and patient pathway length. I have two updates on the business case version that you have. First, a paragraph in the recommended options section at the top of page 4 is incorrect and needs to be removed. Application of VAT or not has caused confusion in the error, so my apologies. It's a complex topic, VAT. This paragraph relates to whether CCG would have been in the benchmark tariffs if option 3A was chosen. The second update is that the business case refers to the equality impact assessment as being in draft format, but it is the signed and final version that is embedded in the appendix. So options 1 and 2 are not recommended due to the risk that providers might not bid, and that adopting either option would also mean risk of legal challenge. Option 4 is not recommended, not felt affordable due to our current system financial position and the ICS being in soft 4, having soft 4 support. The recommended option is 3A, which is a continuation of the 5-year patient pathway at an increased tariff. And this is following a benchmarking exercise. There's also the introduction of a new tariff for assessment without audiometry if earwax is present. And we've introduced this listening to providers at the supplier engagement event and also at the clinical executive team, clinical executive committee, and about introducing self-referral as a route to access the service, which is a positive. So it won't just be through the GP practice. I acknowledge the 5-year pathway is not in line with commissioning guidance, but because, as I say, of the financial situation we're in, and we have got mitigating actions, including the continuation of the replacement A tariff, and the ability for providers to issue a new aid if hearing loss changes significantly in the five years. Clinical Executive Committee did not raise this as a significant concern, and it was deemed a low risk with the mitigating action in the quality impact assessment. I have been passed a query from Kathy Branson, which I just want to pick up now. She has said that there's an issue with patients on the specialist pathway with severe hearing loss and to do with retubing and wax clearance. Just to note that we have got the earwax pathway in our specification, which includes self-care and microsuction, and Dr. Lim's team are undertaking a review of microsuction provision across Norfolk and Waveney, so that should clarify the matter further. In our age-related spec, we have got KPIs around patient outcomes because based on patient feedback, we know there are issues with tubing and that they don't get the benefit that they could do from their hearing aids. So we want to capture that through the KPIs. And once we have the AQP providers identified, I do want to set up a regular forum between them and the NNN initially, just so that we can have sort of quality and clinical discussions sort of facilitated. I think that will be helpful in terms of strengthening the pathway and relationships. So, Kathy, I hope that answers the issues that you raised, but I'll email you afterwards to make sure that I've covered off your queries. So I suppose that's it for me from an introduction. Happy to take questions before we move on to the recommendations. Thank you.
Okay, thank you very much for that, Karen. John, did you want to make any comments in terms of finances? Because some of the kind of recommendations on options are based on benchmarking that historically we're lower, but also on affordability for some of the options which might put an excessive risk. Are you, from a finance point of view, are you comfortable with the recommendation that's made in terms of the financial impact?
Yes, in short. So option 3A seems the best option, if you like, from a financial point of view. Clearly, there is a significant cost pressure that's coming through this, but I think all of the work that's been done has shown that we've minimised that as far as we can, and that it is just recognising the cost of delivering the service which we need to commission. And we did have a review, as Karen said, at the Finance Committee, which did consider the different options and what we felt would be appropriate from a financial point of view. So yes, whilst it is a cost pressure and will add to our financial burden, I think it's been through a good, proper process to establish that.
Okay, great, thank you. So let's broaden it out. Any questions or comments before we move to the recommendations and asking for your approval? Okay. Well, in that case, we're asked to. Oops, let me just get the paper in front of me. Do you want me to go through the recommendation, Karen, or did you want to say anything as final comments?
No, that's fine. Over to you, Dr. Zessi. Thank you.
Okay, thanks very much. Well, governing body members, we're asked to review the business case, which we've done, and I can report that it's gone through the clinical executive, and to approve the recommendation of option 3A plus the self-care referral tariff. We're asked to review the service specification and to approve its content and approve that the CCG can go out to procurement. So can I ask you to approve those three recommendations? Okay, great, thank you. I'll take that as approval. Thank you.
Thank you very much.
Thank you, Karen, very much for that.
Bye.
Okay, so let's move to item 11, which are regular standing items 11 and 12. Firstly, the clinical thresholds recommendations. So we're asked to review and approve recommendations made. And Mark, I think we can take as read that people have gone through the papers. Do you want to just outline what we're being asked to approve today?
Thank you, Chair. So there are several policies which are unchanged following review and circulation to lead clinicians across the system, and there are specific changes to the policy in relation to corneal cross-linking and to basically the use of fresh and frozen embryos for assisted reproduction. Again, the clinical comments are contained within the paper, so very happy to take questions, and I recommend approval of the policy. Thank you.
Okay, thank you. And as before, this has come to clinical exec, so it has had a clinical discussion, and it comes with approval from the clinical executive to make recommendations. Any questions or comments on any of the reviews that have been done and the recommendations that are being asked to be approved? No? Well, can I then ask you to request requesting clarification of the reviews and revised processes? Can I ask you for your approval for that? Great, thank you. Suddenly, from being 2 minutes behind scheduled, we're 5 minutes ahead. Great. Item 12, similarly, we have a regular item where we ask to review and approve recommendations from the Drug and Therapeutics Committee, and you've got the papers in front of you. And I think we've got Michael.
Chair, I'll happy to take questions on this item as Michael's on sick leave. Thank you.
All right, apologies. I thought Mike was here. So any questions first of all on the recommendations that we're being asked to approve from the Drug and Therapeutics Committee? Again, it's come to clinical executive. John?
Not a question as such, but just a comment. So in the recommendations for October, there is a financial implication. We've had some discussion offline. I understand that this is as part of a nice recommendation that we have a duty to implement. So it's not a discretionary decision effectively.
Okay. Thank you for that clarification. Any other comments or questions? No? Okay. Well, we're asked then to approve the recommendations that have been made. So can I ask for your approval of those recommendations set before you? Okay, great. Thank you very much. So we're on item 14, which is a financial report for month 7 from John, Chief Finance Officer. Over to you, John.
Yeah, thank you, Anoop. So just a couple of things to say by way of introduction. So first of all, a reminder that since the COVID pandemic struck about 18 months or so ago now, we've had a national interim financial framework that's delivered additional funding to systems. And also we've been planning in 6 monthly periods because of the uncertainty, I suppose, within the NHS as a whole and within NHS finance. So therefore, there's 2 aspects to this report. One is an update on where we're at in terms of year-to-date position, and the other is asking for approval for the plan for the second half of the year. So the year-to-date position that we're reporting after 7 months of the year is the same as we reported after 6 months, which was a gap for the CCG of £5.9 million, driven by costs above funding levels within continuing healthcare and GP prescribing. The context for that, though, is the overall system, including the CCG and all the NHS providers in North Waveney. That's balanced overall. So there's underspends within providers that's offsetting the overspend in the CCG. So if you're looking at it from a higher level, if you like, North Waveney system is balanced. So then when we move to half two planning, again, as a system, we're balanced across all the organisations, but it was also really important to make sure that each organisation was able to deliver a balanced plan, because as a CCG, that's a statutory duty that we have to live within our means. So it's important to do that. So the half two plan that we've got that's covered in the paper today shows a surplus of £5.9 million in the second half of the year to offset the gap of £5.9 million in the first half, so that by the time we get to March, we're showing a break-even balanced position. Important thing to note within that, though, is that there's around £10.5 million worth of support that's helping us. So that's partly income that we're expecting to bring in as a system from the Elective Recovery Fund of about £6 million, and then about £4 million of support effectively from providers who otherwise might have made an underspend in the interim financial framework. So again, the way the financial framework works, a lot of the money we have as a system flows through to the providers. There's not a lot left within the CCG to cover those increased costs of things like continuing healthcare and GP prescribing. The other thing to note in terms of the second half of the year is that, in line with other system partners, we are focusing on delivery of efficiency savings. We've got a target of around £10 million focused on continuing healthcare and GP prescribing. And at the moment, we've got a gap in terms of the savings that we've identified. Now, we have got non-recurrent mitigations for that gap this year, but the key thing for me, and the key thing really we discussed at the Finance Committee last week, was the need to really identify those savings on a recurrent basis, so that by March, we've identified £10 million reduction to our cost base that can help us go into next year. If we just cover it off by non-recurrent means, that means we're starting very much on the back foot for next financial year. So that was the main focus of discussion through the Finance Committee when we saw a previous version of this paper a week or so ago. So that's all I was going to say. The paper's here to note the month 7 position and to ask for approval for the plan for the second half of the year.
Great, thank you, John. So any comments on the paper? Yeah, Hein, as chair of the Finance Committee.
Yeah, thanks, Chair. Just to confirm what John just said, I think on the positive side, there's good system working, as is evident in the paper, and partners looking at the total system picture. But as John said, it's important that each partner organization also balances its own books. We did indeed discuss it in the Finance Committee. There's about 6.4 million at this point of efficiency savings not yet identified, and of course already 6 or 7 weeks into the second half year period. But exactly for the reason John mentioned, is not just to deliver recurrent savings this year, but also in the period beyond, that it's appropriate that it has the attention also of the executive in seeking for those efficiency savings. So that's where we spend a fair bit of time on in the Finance Committee. And that's all. Thank you.
Thank you very much, Hein. Any other comments or questions from anybody? No? Okay, thank you. Thank you for that report. So we're asked to note the month 7 position and seek approval for the financial plan for the remainder of the year, which, as John outlined, puts us in a balanced position at the end of year, but also addresses some of the recurrent deficit that we're planning. And Patricia's still watching, so you'll be pleased to know, Patricia, that we're hoping to hand over to the new body in a balanced position.
Thank you. That will be much appreciated by the Integrated Care Board.
So can I ask the governing body to approve the financial plan for the remainder of the year? Okay, great. Thank you very much. Okay, so let's move on to item 15, which is the governing body assurance framework, which we're asked to review, and I'll ask Karen to take us through any changes since the last review we did.
Thank you, Chair. Apologies if some of you haven't seen the covering paper that went with this. It was on the Teams, but I think it may have got slightly lost in the huge PDF pack. But just to summarise for you, there were 2 changes since the last governing body, in addition to the usual updates that you'd have expected. The first change was around primary care pressures and the risk on that, which was GBAF 7, and that has been deemed to be increased through looking at it through the CCG systems. The second change was on GBAF 8, which is Mental Health Transformation Programme, and that risk has been seen to go down. The rest of the risks have been updated and gone through our usual systems, and they're here for noting today, and I'm happy to take any questions. Also, the officers in charge of each risk are also here and able to help with any detail as well. Thank you, Chair.
Okay, thank you very much, Karen. So you've got the assurance framework there, the 2 changes, an increase in the risk for primary care and a slight reduction in mental health. So any questions on that review, which you were asked to note, or any comments? Okay, great, thank you. So I'll ask you to note that report, really, so we're not asked to approve. Thank you. Okay, so item 16 is, let me just quickly get the papers up. So it's to receive a report which Kath is going to present on emergency preparedness, resilience and response and updates. Kath.
Thank you, Chair. So the annual EPRR core standard submission was submitted to NHS England by the 31st of October, which was the submission deadline. This part of this was that larger providers within Norfolk and Waveney undertook self-assessments against the individual core standards. As a result of the submission, there are no particular areas of concern to highlight, and actually when this was gone through with NHS England, they were content with our submission. So I think the final thing I just wanted to say is where there are areas of not full compliance, there are action plans that have been submitted and they form part of the appendix, and those action plans will be reviewed by the Norfolk and Suffolk local health resilience partnerships in order to ensure consistency and scrutiny over the agreed actions. So I'm proposing to stop there, Chair, and myself or Karen Barker, who's particularly involved in this programme, are happy to take any questions. Thank you.
Great, thank you very much, Kath. So any questions for Kath or Karen? Any comments? No? Okay, so we're asked to note the contents of that report. So we're on to the final section, which is to receive reports from the committees and the clinical executive. So item 17, and you've got the reports in front of you. So Kathy's presented the report from the Quality and Performance Committee, which you have in front of us. And she's here, but she's happy to answer questions, but has lost her voice, so be kind to her. So any questions or comments on the quality report? No, which thankfully was very comprehensive. Great, thank you. Next, we've got item 18, which is a verbal report from Hein on the Finance Committee. Hein.
Yeah, thank you, Chair. John already covered earlier the month 7 results and the plan for the second half. We also took the opportunity in the Finance Committee to hear from the plans to address the financial overruns in continuing healthcare and prescribing. So there's a number of initiatives underway on in both of those areas, and we will continue to receive updates in the months ahead. I'll leave it at that. Thank you.
Okay, great, thank you. And if there aren't any questions, we'll receive the report from Primary Care Committee, which Doris chairs.
Thank you, Chair. I take the report as read. I think the one thing I want to draw the governing body's attention to is the progress that is being made on reviewing the locally commissioned service. It's a huge piece of work that had been deferred because of the pandemic. And it's really good to see some traction now. We have a very tight timetable for implementation in 1st of April. So I just want to thank the team for the work they've done up to date and keep up the good work.
Okay, great. Thank you. Thanks very much, Doris, for your report. Item 20 is the report that you have from the Audit Committee, which Rob chairs. So, Rob.
Yes, thank you, Chair. It's a short report, Chair, covering the key points from our September meeting. Again, I'll take the paper as read, but I'm very happy to answer any questions that anybody has.
Okay, great. Thank you. I'm not seeing any questions or comments. And finally, in this section, we've got the report from the clinical executive of the CCG, which I chair, but very effectively supported by Mark Lim. So, Mark, did you want to make any comments on the report?
Thank you, Chair, for your kind comments. Yes, I'll take the report as read. There are three main pieces of work at the moment. So one is the clinical workup of the locally commissioned services, to a very tight timeline, as Doris has mentioned. The second is the oversight of the clinical interface work, so much closer working with our provider colleagues on issues such as referral pathways and discharges. And the third main area is that we are standing up again a lot of the training and development activity which we previously had before the pandemic, which has been well attended, and we'll be going forward with the next event next month. Thank you.
Okay, great. Thank you very much for that. So we've reached the end of that section, and the item 22 is to receive any questions from the public. So first of all, Karen, have we received any questions prior to the meeting or during the meeting which we need to report?
Yes, Chair, we've received one question ahead of the meeting. I can share that with the board now via PowerPoint, and I've circulated it to the board. So this was the question, and you may have had an opportunity just to read this ahead of time. We will be putting this on our website as well. So if people don't have quite the time to read it now, we have issued a response as a CCG to this question to the inquirer, and that is also going to be added to our website again for people to read at their leisure. If I can just ask for the slide to be moved to the answer. Again, there's quite a lot there, but it will be on the website. I'm not aware, Chair, of any questions that have been raised during the meeting.
Okay, thank you. Thank you for that. There aren't any other further comments on that question. Then I'd like to welcome. Hi, Richard. Welcome to the meeting. I guess you've got a question you'd like to ask.
Yeah, I don't know where to be started, really. I wasn't going to ask any questions today, but there's two specific questions and one more general one. On the mental health issue, you suggest there were 12 additional beds being rolled out, and I just wonder what the latest is on the rollout of the various STEAM initiatives, because I have attended the one in Galston, which was initially, and I know it's going to be rolled out, the walk-in centres throughout Norfolk and Waveney. To be honest, I think the one I've been attending, the STEAM one in Galston, is very good, really, in terms of very open and walk-in, and people can discuss things, although it's a bit too much open stuff. That it doesn't seem to be enough rooms where you could have individual talks rather than the open public area. That's just one aspect of that. So I just wanted to run out of that. Second one is on the Queen Elizabeth Hospital. It's nice to see that, in fact, they've got an award, but I just wondered whether Melanie might know, or Patricia might know, whether, in fact, there's going to be funding for a rebuild of the Queen Elizabeth Hospital under the Comprehensive Spending Review, or is that whether that's coming up under some other capital thing. So that's the two specific questions. Do you want me to answer those before going on to another question?
Yeah. Okay. We'll. So who can answer the question to give additional information on those additional mental health beds to start with?
Chair, I'm just looking for the answer, but maybe what I suggest I could do is to contact Richard directly, but also provide the information specifically so we can upload it on our website as well. That's okay. And the other point about the community cafe clinics, I wonder also whether or not a direct conversation with Richard to get his specific feedback and observation, which would be really valuable. And then we can make sure that this program
would be really useful for us, wouldn't it?
Would that be okay, Richard?
Yeah, but I as I understood it, they were going to be rolled out in north Norfolk, in Kings Lynn, maybe another area in Norwich. I wasn't too sure what the present status was in terms of rolling out that facility there. So you probably, I mean, my understanding from 2 months ago or 4 months ago that the money had been agreed and Access Community Trust was opening these facilities around Norfolk and Waveney.
Yeah, we've got all the information. I just need to find it, so I think it's easier to contact you directly if that's okay. But we will publish that information as well, so that anyone who wants to access it can find it on the website.
Okay, so we will answer the question in detail as requested and liaise directly with Richard as well on those. Mark, are you trying to come in to answer or clarify some points on this?
Yeah, if I may, Chair, thank you. And Richard, in relation to those 12 beds, that's in direct response to the winter pressures that we're seeing. So it's working across ourselves as commissioners, the acute trusts and the mental health trust, recognising that the demand that we are seeing is even above what we were expecting and had been modelled. And therefore, it is felt that to support patients with mental health need, we did need to take additional steps. So it's specifically relating to our winter plans for those additional 12 beds.
Great, thank you. And Richard's second question was on the Queen Elizabeth Hospital and whether we have any further information on the capital bid. Who is able to?
I'm happy to come in there. Richard, hi, and it's a shame that Dr. Arden Ross, who you know, is on. She's had to send her apologies to the meeting today, and as you know, Arden's our mental health lead, so would have given more information as well, but to what Kath and Mark has said. But we'll make sure you've got the very latest update on the situation. And in relation to the Queen Elizabeth Hospital, the hospital has been allocated some investment to make the hospital safe, and that just for a short period of time, but there is still no long-term financial plan for the Queen Elizabeth Hospital, which is very regretful. The governing body and all of the organisations within Norfolk and Waveney are making the strong case to central government, supported by the NHS, but as you'll also be aware, there are many other competing pressures. But we continue to strongly make the case for the Queen Elizabeth Hospital and indeed for the population that it serves for a long-term financial investment. Richard,
do you know if you've got support from the MPs in Norfolk and Waveney?
We've got very strong support, Richard, from all of the MPs, including Liz Truss, one of the local MPs, and a senior minister, as well as James Wild, but indeed all of the Norfolk and Waveney MPs, as well as the Norfolk County Council, and indeed Kings Lynn and West Norfolk Council as well. So everybody within Norfolk strongly sees the need, as does the NHS region as well, and the national team, and are really pushing the case for a longer term financial investment for Queen Elizabeth Hospital. And Richard, you'll know when we've heard, because it will be celebrated very publicly.
Okay, thank you. Thanks for that.
I've just got one
Okay.
I've got another question. All right. Is that
yeah,
okay?
fire away, Richard.
Yeah, I don't know where do I need to start on this thing, on the establishment of the ICS. It won't be a secret. I'm really actually rather against the legislation going through Parliament, but it doesn't seem to be. I mean, it's already been rolled out, isn't it? I mean, the ICS and it seems to be being rolled out. And it's a question for Patricia, really. Once the ICS has been established, in terms of democratic engagement, will it be open to the public like I am at the moment speaking, or will it be just for stakeholders in part of the new organisation, the new constitution? And if that is the case, whether recognised trade union representatives will be on this board. But to just add to that, which I think is tied in with this really, is which John was introducing the share record. It's obviously being railroaded. It's obviously been rushed through. My understanding that there's already, you won't need to actually have tender. It'll be. I'm not saying it'll be a VIP run, but there's already been all the framework agreements have been signed with private companies in terms of who will be handling certain issues within the NHS. And I don't know what's responsible for digital and communications and data control, but I imagine that's what's going to take in place. And it seems, I would have hoped that in fact the CCG may have not been, I know that it seems to me that they're over a barrel in a sense of financially they've got to break even by April, but it just seems like we're already there. I mean, the fact is you're rolling out the ICS like a company. I mean, it come to the end of the year in April. If you're not breaking even, what will Patricia do? Will she call in an outside auditor to look into the finances? And this is where it's all leading to, and that's why my concern about the whole development of the ICS, which goes back 20 years, really, to be honest. Anyway, thank you. That's just just a comment. All right, but it's a lesson. One is about engagement. All right, thank you.
Sure. Let me.
I mean, before Patricia comes on, I just ought to say that obviously the first thing that I would say is that the ICS hasn't just suddenly arrived. We are actually across Norfolk and Waveney already an integrated care system, which Patricia chairs, and the long-term plan, which came out over 2 years ago, signalled the direction. So this is just the next stage in what has been happening over, as you say, over a period of time with the SDP previously. And I don't know, first of all, Melanie, whether you want to make any comments as a current ICS executive lead in terms of this isn't actually a new thing that's unexpected. And then I'm very happy for Patricia to come in as well in her current role as chair of the ICS and in her future role, which has now been established as well. So Melanie first.
Thank you, Anu. Richard, the first thing to say is have you discovered the interim partnership board meetings, which is the almost predecessor to the ICS, which is meeting in public, and you can get the link and join the meetings just as you're doing with this one. In fact, I think the next one is in the next couple of weeks. So, you know, if you haven't got that, I know you are a very important follower of NHS business, and we really value your input, and I will make sure that you have the details so that you can start to observe. It's very much the predecessor, but to what will then, subject to passing of the bill through Parliament, be in place in April. And just as Anoop said, this has been in development probably for the last 2 to 3 years really, and it has been more of an evolutionary reorganisation and new legislation, but it is part of a big national reorganisation, so there isn't a choice for CCGs in this. It's a national reorganisation, and the CCG is preparing to become an ICB, and which is, has lots of different functions as well as the CCG currently does. But if you are able to observe the new ICB that will meet in public, just as this does, and participate and have the opportunity to answer questions, you will recognise a lot of the business, because whilst there will be a great deal of a new focus, a lot of the business will be very similar. You'll recognise that, Richard. So there are elements that are changing, but I think the general view from within the health service itself and partners is that it's one of the more positive developments that we've seen, because it brings in the voluntary sector more, it brings in social care more, and the NHS is opening its arms more fully to those sectors, which I know you are a big supporter of as well.
Thank you. Tricia, do you want to make some?
Yeah, I mean, let me build on that. And Richard, thank you very much indeed for multiple questions and obviously great concern about it. Totally agree with, of course, with what Anoop and Melanie have just said. And in a sense, I want to reinforce that, because actually what we had as before we became an integrated care system was something clunkily called the Sustainability and Transformation Partnership. And that was set up nearly 5 years ago. And the initiative for this came from the NHS, came from Simon Stevens, who was then the chief executive of the NHS, recognizing that actually we needed to move away from the era of competition between different bits of the NHS to collaboration. Collaboration between all the different bits of the NHS, primary care, the hospitals, mental health, community, and so on, but also much closer working with social care and public health, but also other aspects of local, and both of those sit in local government, of course, but also other aspects of local government, helping to improve housing, for instance, or make it easier for people to lead active, more healthy lifestyles, that sort of thing. So this is not sudden, and it certainly isn't being imposed on the NHS. It's what the NHS has actually said it wanted, including the bill. Now, in terms of democratic engagement and openness to the public, as Melanie said, the interim partnership board, the next meeting of that in public is on the 7th of December. The link to that, or the email thing, will be on our website. And when we get to next April, there will actually be 2 new bodies making up the new integrated care system. One will be the Integrated Care Board, and I'm the chair designate of that. And as Melanie said, that will meet in public exactly in the way this CCG governing body does. And then there will also be an integrated care partnership for Norfolk and Waveney, with a much wider membership, including all the district councils, many others from the voluntary sector and so on, probably with almost exactly the same membership, in fact, as the current Health and Wellbeing Board. And that too will meet in public, and both will have the sort of facility that we have at the moment for members of the public to ask questions and have that dialogue. We already have, as part of our integrated care system, a social partner forum with the trade unions, and that will continue. And the shared care record, far from being, well, the funding is being rushed through, and that is a little frustrating. But actually, this has been in development for a long time, and there are many other parts of the country who already have their shared care records in place with all the benefits that Dr. Blake was describing. But I remember the initial thinking about the shared care records actually being presented to what is now the Interim Partnership Board probably 2.5 or 3 years ago, because it was certainly well before COVID. But I look forward to seeing you on the 7th of December.
Just to add, if I would just be excused, just to ask a supplementary question or that. Well, why do you? I mean, I could understand sharing, developing patient records. I mean, I've been in the hospital only last week, and I was, to be honest, I was helped by the fact that going back 20 years, records of my attendance, and that I can understand that, and I could understand that in terms of mental health as well. But why do you actually need to have it go out to third party rather than actually having in-house? I mean, it just seems to me that, in fact, that I just don't see the case for it. I can see the case for it in terms of, as I said, in terms of health issues and in terms of patient records and everything, because that's something that helps patients and helps the public, but not in the sense of actually outsourcing it, because then, I mean, I have stated I don't think you'll be a tendering process anyway. I think there's already an agreed framework agreement with approved companies who will be just which they're probably a bit of a face saving there, but that's probably why there's not really been sure the bidding process has been concertinaed in that way. But I can see that. I can't see the point. I can see the point of it inside the NHS. I can't see the point of putting it out, and then the dangers of the data being sold on. I know you've got an opt-out and everything, but this is a thin edge of the wedge, really. I mean, that in fact data may be lost. I mean, we know the difficulties with Facebook and everything about data being misused. So I mean, it's a dangerous course. That's all I'm saying. And I don't know what checks and balance you think you may have in the future if this all goes ahead. Thank you.
Thanks for that, Richard. And I think your concern certainly would be shared by a lot of people. I know John wants to come in, but one observation I would make is that that when you say in the house, what does that actually mean? When you look at the suppliers of information software and what's used currently and in the past, in general practice, for example, the systems that have been developed developed outside of the NHS. There have been providers that have come in and provided solutions, and the NHS doesn't have its own sort of software engineers and organisations. So it's always relied on external suppliers, and that's where innovation comes from. It doesn't come from within the NHS as a body. It comes from outside, and it's as long as we protect the information, we want the right experts to provide those services, as they always have done.
All right. Yeah. All right. Thanks,
John.
Yeah, I understand. Yeah.
Thank you.
Just briefly to add a couple of comments to that, Richard, information governance is paramount really in what we do on the shared care record. We've got a particular work stream with local IG experts from within the NHS guiding us on this, and to be honest, that's one of the reasons why we're looking to procure it through a framework which includes providers that have been nationally accredited. Part of that accreditation is about actually the highest standards around information governance and security. So that's all embedded into that process. And having said that, though, the longer term solution for the system, our digital strategy, is actually to develop a very large data platform, effectively of our own within Norfolk and Waveney. So we're not so dependent on other third parties, but that's some way off at the moment, because that's a huge task in itself to develop that. So that's something that will run in parallel with what we're doing now with the procurement of the shared care record. As Dr. Blake said earlier, there's a lot of benefits that we're missing at the moment because we don't have what's in place in a lot of other parts of the NHS. We want to get those benefits now, but at the same time we want to develop the longer term solution for Norfolk and Waveney, which would be more building something in-house.
Yeah, thank you very much for giving me the occasion to ask these questions. Thank you very much.
Thank you, Richard, for those
all right. Yeah.
Size of questions. So, so if there aren't any more questions, can I then ask, is there any other business? Okay, well, can I thank particularly the team for producing the papers, and I know they were quite long, but they did need to give you some of the detail today. So thank you for attending the meeting. Just a reminder that the next meeting in public will be on Tuesday, the 25th of January at 1:30. And just a reminder for governing bodies that we've got a Part 2 meeting, which I suggest we convene in 5 minutes' time, so at 3:45. But I'll draw this meeting to a close now. So thank you very much for coming to this meeting. Thank you.